Thank you for your attendance. And also good morning to anyone that might be out there listening and watching this morning's proceedings. Unfortunately, for a whole variety of reasons, we haven't met for quite some considerable time, but that's been through force of circumstances rather than choice. So I'm going to pass over to probably Craig, I think, now, to explain how this this meeting works. Can I just ask that anybody that is watching is patient with us, because for some of us this is a brand new experience. There's always the chance that technology may go wrong, and a number of us will be trying to juggle probably 2 or 3 different bits of IT equipment so that we can see the various papers that make up this morning's meeting. So if we're looking here, there and everywhere and slightly confused and at times panicky, that's why. Craig, are you ready to say a few words?
Yeah, I think it'd be Jenny.
It's me, Chair.
I'm sorry, Jenny.
It's all right. Okay, right. Thank you for logging on to this Zoom video conference of the Joint Health Overview and Scrutiny Committee. I am the Democratic Services Officer for this meeting. I'm assisted by my colleague Craig Rogerson, who is the host of the virtual meeting. We will proceed to introductions and housekeeping in a moment, but just a couple of points to note. This meeting is a public meeting and, in alignment with the new regulations which permit meetings to be held by remote means, will be live streamed for the public to view. To make the meeting run as smooth as possible, can I please ask that participants in the virtual room leave your microphone on mute when you are not speaking. When you want to speak, please raise your hand to the camera or use the virtual hand raise. Only unmute when the chair indicates that you can speak. If at any time any member loses the ability to hear or be heard, they must alert the chair or the host as soon as possible. You may see members looking away from their screens at times. This is because they will need to look at an additional screen or device containing paperwork. I will now hand over to the chair of the meeting, the introductions. Thank you, Chair.
Thank you very much. Well, we'll go around including elected members and officers who will be taking part in today's meeting. There may be 1 or 2 people that join us a little later. When that happens, I'll ask them to introduce themselves at the most appropriate point. My name is Councillor Rooney. I'm from Sheffield, and I happen to be the chair, at least for the time being, of this particular meeting. And in no particular order, except that this is the order that I'm seeing them on the screen, I'm going to ask the rest of the today's participants to introduce themselves. And I'll start with Emily.
Hi, I'm Emily Stanbrook-Shaw, Policy and Improvement Officer from Sheffield City Council. I support this committee.
Jenny, do you want to say anything again, or do you think people know you by now?
Yeah, just take the minutes of the meeting.
Thank you very much. Craig?
Yeah, Craig Rogerson, Sheffield City Council and host to the meeting.
Thank you. Jackie?
Hi, Jackie Wardle. I'm the Improvement and Scrutiny Officer who supports the Derbyshire County Council Health Scrutiny Committee.
Thank you very much. Alexandra, is it Norris?
Norwich. Hiya.
Norwich.
So I'm the Programme Director for the Hospital Services team, which includes both stroke and children's services.
Thank you very much. Anna.
And, sorry, I just, apologies for answering the phone just then. It was a message from Will Cleary-Gray, who unfortunately sends his apologies. He's been pulled into something from a national call that he needs to take, so he probably won't be able to join us.
Okay, thank you very much. We'll add his name to the apologies list. Okay. Anna.
I'm Anna Marshall. I'm the Scrutiny Officer supporting Barnsley Council.
Somewhere in there is a Councillor Taylor. Is it slightly in the dark? But would you like to say hello to us?
Hello, Councillor David Taylor, Derbyshire, always in the dark.
The mushroom theory, isn't it, with council?
It works.
It works, yes. Caroline.
Caroline Martin, Senior Governance Officer from Doncaster Council.
Thank you very much. Councillor Ennis.
Councillor Jeff Ennis, representing Barnsley, and I'm Chair of Overview and Scrutiny Committee on Barnsley Council.
Thank you very much. I've got Leslie now.
Good morning, I'm Leslie Smith and I'm Deputy Lead for South Yorkshire and Bassetlaw Integrated Care System and Accountable Officer for Sheffield and for Barnsley CCGs.
Thank you very much. Anna.
Hi, Anna Clark. I'm the Children's Network Manager for the South Yorkshire and Bassetlaw Integrated Care System.
Thank you. Councillor Robinson. Hopefully we'll learn Councillor Robinson's first name.
Hi, Councillor Andrea Robinson. I'm the Chair of the Health and Adult Social Care Scrutiny Panel in Doncaster.
Helen.
Good morning, everyone. I'm Helen Stevens and I'm the Associate Director for Communications and Engagement in the South Yorkshire and Bassetlaw Integrated Care System.
Yes.
Hi, I'm Des Breen. I'm the Medical Director for the South Yorkshire and Bassetlaw Integrated Care System.
Councillor Keenan, who is also going to tell us what her first name is.
Good morning, Chair and everyone. Yes, it's Councillor Eve Keenan from Rotherham, Chair of the Health and Scrutiny there.
Yeah. James. Can't hear you, I'm afraid. Are you muted? Nope.
Can you hear me now?
Yes.
Apologies for that. I'm not sure what happened there. I'm James Scott. I'm a Senior Programme Manager with the South Yorkshire and Bassetlaw Integrated Care System.
Thank you very much. Jamie?
Good morning, everybody. My name is Jamie Shepherd and I am the Network Manager for the South Yorkshire and Bassetlaw Stroke Hosted Network.
Thank you very much. And I have a Catherine Hall. Anyway, I've got a name here without a face. I don't know whether that's because they can't get in or... Hello, is there anybody there that can hear me?
Good morning. This is
Hello.
Catherine Harklerode. I'm the Governance Advisor at Rotherham. I support Councillor Keenan on the Health Select Commission there.
Okay, thank you very much. Right, that's that. Apologies for absence. No, none. Exclusion of press and public, no reason to do that I'm aware of. Declarations of interest on today's agenda. No one is making any declarations. I'm assuming everybody's got an agenda in front of them.
Chair.
Have they?
Chair.
Yes, Councillor Ernest.
Sorry, Chair, I couldn't do my mute button. On declaration, I'd like to declare my interest as a non-executive director of the Barnsley Healthcare Federation.
Okay, duly noted. Thank you. I'm assuming that that's not an interest that would stop you from taking part. I'm looking for you're just making sure that people are aware. Yes. Okay. Thank you. Oh, yeah, as I was saying, has everybody got the agenda and stuff in front of them? Yeah, I'm getting nods from everyone, so we're okay there. Right, minutes of the previous meeting. Was anybody who's there prepared to accept them as a correct record?
Move that course of action, Chair.
Second it.
Okay. Right, thank you. That's very helpful. Has anybody any objections to that? I can't see any. And now we'll go through matters arising. Now, one thing that I have noticed throughout the minutes is that there are a series of questions that were asked by the general public, some of which are contained within the item on public questions. Now, what Emily and I are proposing, and I'll put that to the questioners themselves when they I'm not sure whether they are appearing or not this morning. I will put it to them that we will find answers to those within the next fortnight and get them to them. So that's my proposal. I hope that's acceptable to members. It seems a sensible way of dealing with it. It's just such a long time that so many things have happened. One large thing has happened in the last 10 months or so. That's the proposal that Emily and I will deal with the outstanding questions within the next fortnight. So is everybody happy with that? Yep. Getting nods from members. That's fine. Are there any other matters arising from the minutes? I just ask my assistant to get to the minutes. Does anybody want to raise anything else from the last time we met? It would be a test of memory, I have to say. No, I can't see anybody that's wanted to raise anything else. Okay, so we are now on to public questions. Emily, how is this going to work? Or Craig, how is this going to work?
I think we've got one. Questions have been submitted from 3 separate members of the public, all belonging to the South Yorkshire and Bassetlaw NHS Action Group. I think we've got one of those people is able to attend. Is that right, Craig? So I think if we bring Nora in and ask her whether she would like to ask all the questions on behalf of everyone, and if she doesn't, we'll read out the questions for the people who weren't able to be here today. That sounds okay.
Yeah. Okay. Hello, Nora.
Hello. Sorry.
How are you?
Technology. I'm fine, thank you.
Good to see you fitting well.
I'm not quite sure which questions you want me to ask. I'm quite happy to ask mine and Peter Deacon's, if the others could be asked by the chair, maybe?
Yes, fine. That's fine.
Okay, and I understand that the questions on the matters arising are not to be discussed today, yes?
We're going to try, well, to be honest, Nora, that we haven't really got answers at this moment in time to them.
Fair enough, fair enough.
But I'll give an undertaking that myself and Emily will do our best to get them to you within the next fortnight.
Thank you.
Okay.
So Peter Deacon's question was about the COVID verbal report. Well, general, it was what protocol is there regarding national emergencies for not informing Scrutiny or the public about how you will keep health and care services accessible and safe, and any changes to services you will be making? That's question 1. Shall I go on to question 2? It's,
Yep.
How in this national emergency and possible second wave of virus infections are you going to inform and involve the public to be sure you are transparent and accountable? And he asked me to ask as well if he's concerned that there are no public information on the website, and there are no meetings of the joint CCCG going on at the moment. So the public are in the dark since the lockdown. That's his questions. Do you want me to read all the questions?
No, we'll take them by person, shall we say? The questions from each person. Yeah. Okay. Does anybody want to answer any of the questions that have just been put?
Yes, Chair, I'm happy to start off with.
Oh, there. So I'm sorry about that. Two seconds ago, you were at the other side of the screen.
And I moved.
Yeah, it's weird. Okay, I'm sorry about that. Carry on, Leslie.
Okay, I'm happy to kick off with Peter's questions. And I think the key thing here is to recognise that, and Peter's correct with this, that each NHS body has a duty to ensure that services are accessible and safe, and report progress on this to their boards and to their governing bodies. With COVID, we entered a sort of national emergency, the NHS operated under a national command and control system. So I know there were questions coming up about the management of the pandemic. From a healthcare perspective, that rested with NHS England and Improvement. In a national emergency, we can make changes to services to ensure that the public are safe. And that happened on a number of occasions throughout COVID. So those changes can be made under, and I quote, Regulation 23.2 of Section 244 regulations, if there's a risk to safety and the welfare of patients, staff and the public. So that's the regulation that applied during COVID. However, where changes have been made, they've been reported to boards and to governing bodies, and local scrutiny committees have been made aware too. And I think Helen might pick up for us on the question around second wave, national emergency and informing the public.
Thanks, Leslie. So I think the key points that I would want to make here are that, as Leslie said, the NHS bodies that have duties to their populations continue to keep them informed and involved, and each of those is carrying out involvement in ways which are overseen through their own governance arrangements. And so in CCGs and NHS Foundation trusts, for example, they have committees and groups which oversee the public and patient participation and also equality and inclusion. What I can say is that I have seen, and colleagues will probably have seen, examples of some of the ways in which those bodies have been informing and involving their local populations. And much of that, due to the situation we're in, has been through social media and in particular Facebook. But also in places like Barnsley, for example, there have been wraparounds in the local newspapers to help keep people informed. In Sheffield, I know that they have been regularly sending letters to the local newspapers as well. And of course, interviews on television and radio to keep people informed. And some of our CCGs have also been carrying out telephone and online surveys to understand people's experiences during COVID. And I think also connecting in with membership bases where they exist. So I can certainly assure you that that all of the participants of the partners in the ICS have been keeping their populations informed. And of course that applies to the local authorities as well, where they have a duty as part of both the local control outbreak plans and also as members of local resilience forums to keep the population informed. Notwithstanding, there is, you'll be aware, massive national campaigns that we all support and jump on the back of. So the materials for those are provided nationally and we localise them where appropriate. I think that explains the involvement process that's been going on throughout COVID.
There was you raised the issue about, you raised it on behalf of your colleague, the issue of a verbal report rather than a written one. I mean, we've had a little discussion amongst ourselves, the elected members, prior to this, and I think that the officers can either contradict me or support what I'm about to say. We believe it's simply that this is not finished yet. It's an ongoing epidemic, and yes, I think it's right and proper that there should be an update on how things have gone, what's been done, what's gone right, what hasn't gone right. But I think a written report might give the impression that this is the sort of an element of finality to it. Well, no. You know, on average at the moment, there are around 60 odd people dying each day from this disease. And I think we have to, at this moment in time, just tell the story as it is. And then at a later date, there will be an in-depth analysis, hopefully when we've eradicated this disease, whenever that might be, and learn the lessons then. I mean, that's the that's a resume of the discussion the elected members had this morning. And I'm just wondering what reaction I could get from colleagues from the ICS to that statement.
I think I would absolutely support that, Councillor Rooney, and I'd also add to it, we've kind of got to remember our lines of responsibility here. So the ICS isn't responsible for the management of the pandemic. As I outlined in my response to the previous question, in a national emergency, we've got a command and control structure in place, which stems through NHS England and NHS Improvement as leading the NHS response. Pandemics are public health issues, and our directors of public health have played a leading role in our response in terms of how we reduce the risk of the spread of a very infectious virus. And all of our response to an emergency falls within the local resilience forums structure as well. So I think we'd have to take that into account and just remind ourselves the link between the ICS and the Joint Health Overview and Scrutiny Committee is the ICS bringing to you updates and seeking your advice and input to our transformation programmes where they may result in service change rather than providing the assurance on a response to the pandemic.
Does anyone else want to make a contribution to the answer? No, Nora, yes.
Could I just ask a rider that you mentioned, sorry, it's about the local resilience forum. There is nothing in the public domain about this. We have no clue what plans they had in case there was a pandemic, which is always a high risk, and we don't know what they've done. The public, that is.
I can't answer that. I don't know if anybody on the screen in front of me can.
And I'm afraid, you know, we're not in a position to answer that for Nora at the moment either.
Okay.
Right. So that, yes, Emily.
So we can follow that up, and also just to flag that there is a lot of scrutiny still going on in each local authority about each area's response to COVID and how you know, how that's working. So you know, we've got a work programme in Sheffield looking at parts of that. So these issues are being scrutinised in other forums, but we can follow up the local resilience forum point and find out if and what information is available for members of the public.
It seems a reasonable question, given the importance of what they're doing, and we'll get you an answer to that, Nora.
Thank you.
Okay. Is there anything else from yourself?
There's a couple of questions on the hyperacute stroke services. Are they appropriate?
Well, I'm just wondering, depending on how much time you've got, whether you would want to ask that, and it's your choice, whether you would want to ask them now or just prior to that particular item.
Maybe
I'll leave the choice to you.
Maybe prior to the item.
Prior to the item.
Are you going to ask the questions by Steve Merriman and Louisa Fletcher?
I will once I find them.
Oh, right.
As I say, I keep looking over here.
Okay. Do you want me? There is one about the COVID from Steve Merriman. Do you want me to ask it?
If you want to ask that one, and then I'll do.
It was related. Sorry.
No, go on. You're okay.
It was relating to the written report, which you've already commented on, but
we'll do it.
He just feels why, you know, it's given the overwhelming gravity of it and the gigantic effort put into fighting it, and the fact that the last JHOST meeting was in November. Why was there no written report for you to consider today about the COVID? You've answered that. And in accordance with the terms of reference, can you as a joint scrutiny committee request and consider a written report in order to form a view on the extent to which the pandemic has been successfully managed, showing comparative data for the South Yorkshire ICS against other ICSs for hospital, care homes and community, and the 6 member authorities in the ICS for similar data and comparative data over time to do with the deaths per 100,000, infections per 100,000, and deaths and infections by profession in NHS hospitals and other sites, care homes and community. So maybe that's for the future.
Well, one of the discussions we've had earlier is the fact that the constituent local authorities that make up this committee may well be doing their own analysis of their own situation. Now, I'm happy to have a discussion outside of this meeting with colleagues to discuss whether or not we should do a joint one across all of the authorities concerned. My only fear with that is that we end up duplicating something that has already taken place somewhere else. But if colleagues feel privately that it would be helpful to have such a discussion, then we'll get it on an agenda. But as I said, my worry is about each individual authority doing the piece of work, and then we're doing it collectively, because people are a little bit on the busy side at the moment. But we will give that some consideration, Nora.
Thank you.
Is that a reasonable reasonable
thank
answer?
you.
Okay, all right. Leslie, were you indicating then, or is it just?
No, I think I would agree with that. And I think it's just to reiterate my point that it's not the ICS that is responsible for the management of the pandemic.
Yeah.
So if members are looking to take that forward, we'd need to give some thought to how to what bodies respond to that in terms of the report.
Right. Now, I think I'm now asking questions on behalf of Louisa Fletcher. Is that all right? Yep.
Yes, please.
And I need to find them. Is this the one there? Yeah. The first one. He says, what arrangements have been made in the plans being discussed under agenda items 8 and 9 to address the likelihood of a second wave of the COVID-19 pandemic? Would anybody like to answer that?
Thank you, Chair. If I may answer that one.
Okay, a voice. Where's the voice from?
It's Des.
Oh, it's Des. Hello, Des.
Yeah, I mean, there was a lot of emergency planning going on at the start of the pandemic with protocols and procedures in place. And we're very pleased to say that actually, as described in the 2 reports, those services actually remained intact throughout the pandemic. And we've learned a lot of lessons which we're continuously updating. As we are coming out of this first wave, some of those protocols are being stepped down, but they're already in place. So should we have a second wave, be it a small one or a large one, we can very quickly put those back in place to maintain the services.
Can I just ask a question? I mean, one of the things that's come up, it's on the back of that, I'm sort of piggybacking and taking a bit of advantage as being chair. One of the issues that's been raised recently is that treatments for quite serious conditions, for example, cancer treatment and such like, have somehow taken second place to the issue of the pandemic. If I was in that position with a family member or even personally, I'd be in a state of panic, thinking, I hope they don't do that again. So I'm just wondering, you may not be able to answer this, but hopefully you would hope that some thought had been given to trying not to lower the importance or lower the importance of other very serious diseases. Are we trying to deal with that question?
You've made a very good point, Chair. Right at the start of the pandemic, we were instructed by NHS England to actually hold off services to prepare for a worst case scenario. Similarly, at the same time, actually, the public actually voted with their feet and didn't actually come into hospital, both for cancer treatments and for other sorts of urgent care like heart attacks, because of the fear. We certainly have got, there's national plans and SYB plans, certainly to try and maintain those services by using other sorts of ways of delivering them. And if a second wave does happen, that we're hopefully going to maintain those services. I think in addition, and Helen may want to comment, when we first saw the pattern of people not presenting, we had, there was lots and lots of public campaigning to try and express to the public the NHS is still open for business, and if they're worried about particular things like cancer, then they must come forward in the normal way, although it's different because it'll be virtual in the first instance.
Helen?
You're on mute, Helen.
You're on mute.
Sorry. I read somewhere that that's the phrase of the year so far. You're on mute. Just to add to what Des was saying, which is there were two reasons why the public weren't using services, and one of them was what Des has described. It was people's fear of catching COVID if they came into a healthcare setting, so they didn't use emergency services in the same way. And the second reason is they didn't want to create an unnecessary burden on hospital staff who were dealing with COVID patients. So for those two reasons, we saw a drop in numbers of patients accessing health and care, and that was across the board. Of course, where that had particular relevance was for patients who need ongoing treatments or access to diagnostics to help support understanding what their issues were. So there's been big campaigns on this. You'll have probably seen them to help people understand that it is safe to use healthcare settings. And as time's gone on, again, people have relaxed their fear. So we are seeing the numbers start to go up.
Well, as long as it's on somebody's radar, I think that's helpful. Councillor Taylor.
Unmute myself, which might be a bad idea. I can tell you firsthand that Derbyshire Health Services have been doing other services. I've actually been involved myself. I wish I hadn't been, but I can guarantee that they are working, which I think is a good thing. I mean, they've got to, obviously, you cut down just to COVID only, you've got a massive problem. So I think, I mean, I wish that touched me, because I must admit they made more damage than good, but that's my personal opinion. But I do know they are doing other work.
Okay, thank you. Leslie Smith, are you trying to indicate, or are you just trying to show that you've got a broken arm or something?
No, I was just supporting Councillor Taylor, having accessed services in 3 hospitals over the last week.
Take more water with it.
I have to keep it raised, so every so often I will stick it up.
Right, okay. I think that takes care of that question. I have another one now. It says point 12, no, page 12, point 3.8, the equality impact assessment, brackets presented to the SY. Oh. Sorry about that. Technically, my assistant has pressed the wrong button. Can't get the staff, can you?
I think it died.
It died, she told me. Okay. Right, I'll
Got
start
it up,
again.
Mick, if you want me to do it.
No, we've done it. We've retrieved the situation. Everything is back on an even keel now. Thank you. Page 12, point 3.8. The equality impact assessment presented to the SY and B JCCCG February 20 identified that the changes would have an impact on some children and families. Brackets carers, lone parents, low-income families, and employment implications. The impact was considered low despite 4 categories being affected. The paper intended for the cancelled March 20 meeting acknowledged that there were identified groups affected by these changes. Why is there no reference to these groups identified in the equality impact assessment as affected by the changes in today's update? And why has there been no commitment to attempt to reduce any such impact the changes will have on these families? Well, can anybody answer that?
Hi, Councillor Rooney, I'm happy to answer that if you're okay with
Yes,
that.
yes, please. Yes, please.
The equality impact assessment is in place to make sure that we consider everything really carefully in terms of the key groups that may be affected by any service change. So while the paper doesn't specifically talk about the impact of groups directly, it does refer to the equality impact assessment, which absolutely did that, where there was substantial consideration given to the effects of the proposal on those groups. So the paper states that the proposed changes to the pathway are not considered to hinder the promotion of equality and diversity. So the 4 groups that were identified were carers and single parents. It was also low-income families, and it was also employment, like you've mentioned. And actually the mitigation was part of the equality impact assessment, which determined that they were neutral in terms of their impact. So for carers and single parents, what we did was we identified that that would be one group that might be impacted, given that they have to travel further for their care and their procedure for appendectomy. And obviously there are services already in place. Sheffield Children's is a specialist children's hospital where lots of children from all over the country transfer to that hospital. So there are services to support families, children and young people, and that includes social care services that are responsive in situations like this. Ambulance services can also support a transfer with one parent or carer, and where that's not possible, arrangements are put in place to get the child to hospital, and local trusts and local hospitals would support that to enable that to happen. There's also the additional travel that will be required, which we've talked about. So Sheffield Children's offers accommodation for one parent or carer overnight. Sheffield Children's Hospital also has a reimbursement scheme for any expensive travel expenses for families, for low-income families, subject to certain benefits. And that's part of the healthcare travel scheme, which is a national scheme that offers that support to families. Local trusts would ensure that no family is struggling to transfer from one hospital trust to the other. And like we've said, that there's those services in place. And in terms of employment, we felt that actually, regardless of where a child's treated, a family member would have to be out off work possibly. So that doesn't seem to impact regardless of where a child's being treated. So all those things were considered. We made sure that there was careful mitigation put in place to ensure that, you know, that the outcome was that then it was a neutral outcome. Can you all hear me?
Yep.
Just say my internet's unstable, so and not just me, but my internet. So moving on from there, during the COVID pandemic, additional protocols and processes were put in place because it was really difficult for people to get additional care for their other children that they may have because of the household lockdown, so you couldn't move between households. So again, extra things were put in place for that process, which you will have heard about. But overall, the equality impact assessment fully balances what's in place and then whether that mitigation was there. So that was all done as part of that process. So I hope that answers that question.
It's a very comprehensive answer, without a doubt. But it just strikes me, how would a member of the public know what you've just told me?
So if a child goes to, so obviously, you know, people would only know this if there was a child that required an appendectomy surgery. So going to the hospital, they will be fully explained. And at the moment, what we've additionally tried to put in, and I don't want to get cut into the section about this, but robust things have been put in place to ensure that children that require surgery are absolutely the only ones that transfer. So it's not children with tummy ache, it's not children with anything else. So this is to make sure that they get the best, safest care. So it's important that those children transfer, and they'll be fully informed and supported when that decision's been made.
Okay. So in other words, it's part of the package of care.
Yeah,
it's part of the pathway.
Yeah.
Okay. Councillor Rooney, if I might just add to that. So as Anna was saying, during COVID, as part of the emergency response, we did move emergency surgery from the district general hospitals into Sheffield Children's Hospital as a temporary measure. And so what we did in order to inform parents of what was going on there was, we had Q&A, pieces of paper available in the emergency department. So if and then we had a whole script which the various clinicians went through with patients. So if the child was likely to be transferred, the parents got a set of Q&A, they got everything written down, translation services were available if needed. So we had all of that in place, and so as we would put the same kinds of provisions to make sure that parents were fully informed if that was a situation their child was in.
Thank you. Has any other members want to raise anything on this question? Nora, are you indicating?
Yeah. Yes, please.
I'm being very lenient here, but go on.
Very briefly, there wasn't much mention of employment mitigation. And speaking as a parent who got the sack in the part-time job that I relied on because one of my children was in a hospital away, that took a long time to get there. And I'm sure that has not changed in the gig sector, as they call it, or whatever they do call it. But a lot of people cannot not turn up for work and keep their job just because their child is in hospital.
Yeah, I think specifically for appendectomy surgery, the child may stay a night, stay in hospital. It's not a long-term expectation. There are in rare cases that a child might be expected to stay longer than that. So for this particular bit, regardless of whether a child's in a local hospital or Sheffield Children's Hospital, it might be that parent or carer, regardless of where, would have to take time off, whether it's a local hospital or whether it would be Sheffield Children's Hospital. So in this particular scenario, that kind of balanced out. But you're right, where there are specialised services that are required from a different hospital. So we have lots of children transferred to Leeds from across the piece for different things. And those kind of costs are looked at by NHS England in supporting families to make sure that they can stay with their families. But that is something that's kind of separate to this, and it's not something I could for you really.
Well, it's national legislation that needs changing. Anyway, I'm now going on to the next question from Louisa.
Chair, I've got my hand up. Chair.
Oh, I'm sorry, Councillor Ernest.
No, it's really reassuring what Anna's just said in terms of the information that's given to parents when their child's accessing service in the Sheffield Children's Hospital, etc. I'm just wondering whether we're actually monitoring the feedback from the parents when their children have undergone that particular course of action at the hospital to make sure nobody's falling through the cracks, as it were. I just want some reassurance on that from Anna.
Yeah, so as part of the emergency surgery pathway, all families had an evaluation, and that was preferred to have taken place as soon as that child had been transferred. And also,
we can't hear you. You've gone.
Oh, sorry.
You've become unstable.
Yes, it seems to happen quite a lot.
Oh dear.
Anna, I can respond to that.
Thank you.
And apologies for the noise in the background here. But yes, so throughout the course of the transfer that we had in place during COVID, we worked with the Patient Advice and Liaison Service at the Sheffield Children's Hospital. So every parent and carer who transferred across on the new pathway was asked to be part of an evaluation of the pathway. And initially we did that face-to-face, and then because of requests about social distancing, we then did it as a follow-up after the child had been sent home as a phone survey. And so we've got a significant amount of patient feedback, and I think some of that was included in the letter that we sent to the joint Overview and Scrutiny Committee on the 13th of June, when we were actually closing down most of the pathway, just to give you a flavour of the kinds of feedback that we'd had.
So could I just ask Chair further supplementary to Alexandra? Presumably that feedback has been very positive from the parents and carers that have experienced the situation.
Yeah, it was extremely positive. So there were references to, the quality of care. To I think the main points that people picked up on were that the experience of transferring had been very smooth, that there had been good communication both in the district general hospitals and in Sheffield Children's Hospital. We had a couple of questions about, could there be more information for parents when they arrived at Sheffield Children's about where to find a cup of tea, seemed to be the main concern, and how to get in and out of the hospital. But it was that kind of level of commentary, and so all of the conversations about care were very, very positive.
Thank you, Chair. I'm reassured.
Okay, right. Next question from Louisa. The report, point 4.2, this is the hyper-acute services update, says the hosted network will be monitoring the delivery of the new HASU model, listing some aspects they will look at. What have they learnt from this, and how have they been consulting with patients about their experience of the new model? Anybody?
I can hear that, please.
Can you hear? Oh, Jamie. Hello.
Hi. I hope you can hear me. It is looking a little bit unstable, the internet connection, but hopefully I'll be able to answer your question.
Okay.
So I came into it in January of this year as the network manager, and the network team has been working with all stakeholders across all services within the pathway to keep an eye on the HASU model. So the network team itself has been participating in daily patient flow calls, weekly check-in calls for leads in each service, and also held a HASU review meeting with key clinicians. We've also set up a number of subgroups with clinical and managerial teams across the network, and have been working with the Stroke Association as well to gather views from patients. What we've seen is that all clinicians are working really well together across the pathway and sharing good practice. There's definitely some close relationships that have been developed. They're working together to help us identify our priorities from a network point of view. Patients are moving through the system as we anticipated. Rotherham and Barnsley patients presenting to Doncaster Hospital a little bit expected, and the number presenting to Sheffield and Wakefield has been a little bit higher. We keep an eye on the national audit, so every patient that goes through a stroke pathway is entered onto a national audit, and that helps us evaluate services and to measure their quality and the quality of service that they've offered. So we've been keeping an eye on those results, and the latest results from that indicate that the HASU services in Sheffield, Doncaster and Wakefield are offering a high quality service overall. And we're seeing a lot more consistency of the services that are received. And I've offered the link to where people can go and have a look at that in more detail. There are some areas for further improvement, and so we've been identifying that with clinicians and with patients. So we know that we need to increase the thrombolysis rate across the region. And Wakefield in particular needs to improve their speech and language therapy service that's on offer, and they're taking steps to do that. In terms of patient experience, that's monitored at the moment through the Friends and Family Test. And I've been looking at the latest results for that from February 2020. and they are indicating that 100% of patients that responded would recommend the HASUs at Sheffield and Doncaster to friends or family if they had a similar problem. 10% of patients would recommend Wakefield. The publication of the friends and family test has been temporarily suspended during COVID, but when that picks up again, we'll be keeping an eye on that. And we're also going to be doing an evaluation report for HASU, which will include some information about from patients and their experiences of the pathway. What we've observed is that the patient flow processes between the hospitals are very robust. There are systems in place that mean that patients can transfer seamlessly between sites. And patients can also transfer directly into rehab units as well, or go home directly from the hyperacute stroke unit. And there are community teams that we can link with to get their support. Early supported discharge is now offered in all places within South Yorkshire and Bassetlaw, and the Barnsley team was actually set up during the COVID incident. So the evaluation report that we're going to be planning to do, and we're hoping to publish that in October of this year. And the reason why we've chosen October is that allows us to gather a full year's worth of data from the Barnsley pathway. And what we'll include in that is patient experience and clinician experience. So we're intending to hold a number of focus groups, maybe carry out some telephone interviews and prepare a survey where we can ask patients and families for their views. One of our clinical leads is actually doing some telephone interviews with patients today, just to get a grasp of what their experience of COVID has been, having a stroke during the incident, and we're going to use that learning. And I think probably that's all I need to say on that question. We do have a performance dashboard as well that's been developed, but again, that's been paused during COVID. So we're hoping that as part of the recovery plan, that dashboard will get up and running, and we'll be able to see in a clear snapshot way exactly how services are doing.
Thank you very much. Thank you very much indeed. Emily, have you been keeping track of the questions? I think, have we dealt with them all now?
There's one more from Louisa Fletcher about the use of the word repatriation,
Yeah,
being a very emotive word.
Yeah, and I can understand that. Basically, they're saying repatriation when people are being sent home from hospital has got some rather pejorative connotations these days. And could you think of another term? You know, and I can understand that. I can understand that. It's a very emotive word to some people.
If I can take that, Councillor Rooney, thanks so much. It's Des. Yes, we do apologise if that did cause any offence. And when we normally talk to sort of parents and families and patients and the public, we use the word transfer and not repatriation. Yeah. The word repatriation really is an NHS technical term for transferring somebody who's had an event in a specialist centre, getting them back to their hospital, their local hospital, because we want to know if there's any delays in that sort of repatriation. So it's a technical term that we use in-house, if you like, but we tend to use the word transfer when it's public.
If you could just be a bit more careful, because outside of the NHS, it means sending people home to place, shall I just say Windrush? Yes. And leave it at that. Okay. Emily.
And there were just two more from Louise Fletcher. One about the workforce plan. Why has the workforce plan not been provided as promised in November 19? And about other documents promised to be sent to members of the public in November 19. I think we've kind of covered that with the mop-up of the matters arising from the minutes.
Yes.
So we'll be in touch.
Okay.
And then we're all done.
Okay. Right. I think we're now on to a substantive item, I believe. Which is the children's update on COVID. A verbal update. Who's giving that?
So I think it's for me, Councillor Rooney, if we're talking about the ICS update on COVID as a whole. So I think just to recap, it is a verbal report rather than a written report, and just to remind ourselves that the ICS isn't a statutory body and didn't hold responsibilities for the management of the pandemic. So the ICS role and our link to the Joint Health Overview and Scrutiny Committee is through our transformation work and bringing our transformation programmes to you for review in relation to impact on service changes for local populations. So during COVID, the ICS had to adapt to support local organisations to enable them to respond to COVID and to facilitate mutual aid. So therefore, in relation to our transformation programmes, we did a piece of work which was about which programmes might we stop for the moment, which ones might we slow down, which are the ones that we need to continue, and which are the ones that we need to accelerate. And an example of that, we did have a question about gluten-free prescribing, I think in the questions list that we may not have covered, and a question about what had happened to that. Well, that clearly was one that fell into the category of programmes that we would put on pause during the pandemic. So the answer to that is, as we come through the other end, we'll start our work on that again and bring it probably to the next Joint Health Overview and Scrutiny Committee.
Thank you.
So by going through that piece of work about stop, slow down, continue and accelerate, what that meant is that some of our core team were able to go back to their host organisations to support in the frontline endeavour in relation to COVID. And some of our team were redeployed to do other COVID relevant work and indeed to support the national and regional incident centre in coordinating the response to the pandemic. We also agreed with NHS England that we would set up a local strategic health coordinating group, and that met, well, it now meets weekly, but for a period of time it met more frequently than that, and enabled each of our partner organisations, so our hospitals and our commissioners, to engage with the national response, and gave us that point of where we needed to deploy mutual aid to support any of our providers across the patch. So some examples of that mutual aid were very much around things like PPE. So huge amount of work was done in South Yorkshire and Bassetlaw about how to source protective equipment for each of our sites, and put mutual aid in place where some of our sites were sort of running short. Also, we mentioned in earlier cancer treatments. So again, our sort of collective approach to that has been a principle of ensuring that cancer treatments progress in line with clinical priorities rather than postcode. So again, there may be mutual aid across SYB to allow some of those cancer treatments to progress. For the team who stayed, one of the aspects of our transformation work was around what are the things that we may want to accelerate during this time. So we've seen massive transformation during COVID, from remote outpatient appointments through to having remote consultations with local GPs, enhanced use of digital solutions to enable that to happen. So a lot of our transformation that had to be accelerated. So our focus was on different areas of work, including that digital agenda and making sure that we were maximising and embedding a significant amount of innovative solutions. So that really covers the ICS role in relation to COVID, a sort of general update on where we're at. Well, I think I'm pleased to say, and you'll be aware of this, that we're seeing an ongoing decline in new cases across South Yorkshire and Bassetlaw. And that's enabling us as a system to start to look ahead to what we call phase 3, which is from August 2020 through to April 2021. And that's all about restore, really, for us. So again, you mentioned earlier about treatments that may have been postponed. So for some of our patients, the risk of going ahead with the treatment was greater than the risk of postponing it for a period of time. But the upshot of that is that waiting lists are lengthening, and therefore we're really in the depths of planning across South Yorkshire and Bassetlaw about how we can bring some of those treatments, particularly planned treatments like elective surgery, back online during this period, being cognizant of what the winter might hold for us in terms of a second peak and, you know, even a prolonged peak of COVID. So particular challenges for us have been the availability of PPE. Again, we've worked collectively and we've worked with partners, and indeed had seen the call from Dan Jarvis, the Mayor, to local industry to support us in the endeavour to provide local PPE. And I think that saw 50 local companies come forward who could change their or refine their production to make PPE available to the NHS. We've done significant amount of work around PCR testing. So that's the swabbing to see if people have the virus. So we have capacity available across South Yorkshire and Bassetlaw to test all of our staff and all of our patients. And that's coupled with the regional testing sites that we now have at Doncaster Airport and at Meadowhall to test all key workers, and equally available to members of the public. And that's also coupled by mobile testing units. So we have them in Barnsley, in Rotherham and the Dearne Valley. Really important to us to go forward because really in our armoury at the moment against community spread of COVID is test, track and trace. So having mobile testing that can respond to local outbreaks or clusters or things happening in our communities, really important to us at the moment. At the beginning of COVID, our infectious diseases site was in Sheffield. As we went into COVID, we realised that we needed lots more capacity in terms of critical care beds and equipment, and we increased our intensive care capacity across all of our sites to deal with COVID. We're probably now in a position that we're able to work on going back to normal. So going back to having our COVID patients in our Sheffield hospital site in the infectious diseases unit, which again will help each of our other hospitals focus on that recovery and getting back up to speed with tackling the waiting lists that are beginning to develop. We've also been supporting our community providers, primary care and community services, and are now turning our attention to how we support people who have had COVID, have survived COVID, but will have long-term rehabilitation and healthcare needs as a result of that. So slightly into uncharted territory in terms of what that means, but something that's really important to us. As members of the Joint Health and Overview and Scrutiny Committee will be aware, each of our local authorities now has very robust local outbreak plans, and key role for each of our organisations within the ICS partnership to support those plans and how they're organised locally in terms of tackling any continued spread of COVID or any further outbreaks. So as I've said, we're moving into phase 3. Probably is important to look back across phase 1 and phase 2 and think about some of the key things that have happened. So we were involved in quite a complex cross-regional development of the Nightingale Centre. So the one for our region was in Harrogate. Des was very much involved in that, both for the region and for looking at how much increased capacity we would need in terms of critical care beds and facilities in our own hospital sites. I've mentioned what we've done in terms of significantly expanding our testing capacity. And I think it's also important to note that more than 600 final year students from Sheffield Hallam University, so nursing students and allied health professionals, volunteered to join the NHS and support in the frontline response. Some of them then would have earlier than would have been expected in their training. I think that's an important thing to note. We've touched on children's services, and again, I think it's important to note between April and June, all emergency surgery for children under the age of 16 years was consolidated at Sheffield Children's Hospital as part of the COVID response, and enabled the support to the other South Yorkshire and Basset Law hospitals as they focused on adult COVID cases. This was, of course, a short-term initiative, and the majority of this emergency work has now been stepped down. In phase 2, so starting from May, significant amounts of work working with our local authorities and again the local resilience forums in providing mutual aid and support to care homes. So for the NHS in particular, that included education, training, development, tutorials on the safe use of PPE and the safe and disposal of items, deployment of specialist hospital equipment to help deep clean rooms in our care homes. And we put in place virtual ward rounds so that staff and patients in care homes had access to senior medical advice and expertise. So we're now into planning for phases 3 and 4. I've mentioned we've got ongoing simultaneously the recovery and how we tackle the waiting list and bring some of those services back online. At the same time, we've got one eye to planning for any future spikes in COVID over the winter, and therefore how we step back up some of the measures that we've had in place during phase 1. You will have heard of the changes to the national flu programme, so we're looking to probably double the flu doses administered this year, and so there's a significant amount of planning going back into that. And we've been working with completely different financial frameworks, so we've stood down the financial framework on contracting as we knew it pre-COVID, and we're expecting those frameworks to continue for the rest of this financial year. And I think probably the key thing to end on, which will be important to the committee, will be engagement and how we look to the future in terms of engagement, both in terms of the transformation that's taken place during COVID and what aspects of that we might want to continue going forward. At the outset, we'd committed to having 2 public events per year that would feed into our guiding coalition meetings. Again, very much committed to engaging with the public in this way. We're exploring the use of technology to ensure that that continues to happen, but perhaps even more importantly, and Helen may want to say a bit more about this, but work is underway to build a new online citizens panel with up to 3,000 people from South Yorkshire and Basset Law who are representative of our population and want to give their views going forward in terms of transformation of health and care. And I don't know, Helen, whether there's anything that you think I've missed that you'd want to add to that.
Well, it was a very comprehensive report, so I'd be amazed if you had. Helen, sorry.
I think in terms of Leslie's report, the only addition that I could make is to the engagement work, which is on the citizens panel, which is about to get underway. I think later this week or early next week. We're just signing off some of the creative materials. The company that were commissioned to deliver this work across the NHS to build membership databases, and they normally do that face to face. So we've had we've had to rethink how we do that, and that will be mostly an online recruitment campaign in the first instance. But of course, we know that that won't reach some of the groups that are seldom heard. So we've got plans to work with the voluntary sector to ensure that we do that as well. So we will start off with an online campaign, and we can send that through to members so that they can see that. Please do share it on Facebook. And then we will start to look at where the gaps are and do some different approaches there.
Okay. Could I just make a suggestion? I mean, Nora and one or two other people are regular contributors to this debate and this committee and whatever. Could you have a conversation with, guarantee that you at least have a conversation with them about the way that you engage with the public? Otherwise, I think they might feel somewhat left out. It's just a suggestion.
Okay. Thanks, Councillor. That's really helpful. Yes, I can pick that up.
You know what I mean? They are the people that take the time and effort to actually read the paperwork and analyse it, put questions to us. I think it would be polite, if nothing else, to ask them. Okay. Anybody got any questions on that report? Councillor Ennis.
Yeah, thanks, Chair. As you said, Leslie provided a very comprehensive response to the concerns. One thing that made my ears prick up was a mention of the Sheffield City region and the liaison between the ICS and Mayor Dan Jarvis, which I think is going to be very important in terms of coming out of the epidemic. And I'm just wondering if you could expand on that a bit, because I know, for example, the NHS Confederation have produced a paper called The Role of Health and Care in the Local Economy, a 5-point plan for every system. In other words, the ICS has got to play a very positive role in helping our economic recovery plan for the whole of South Yorkshire. And I just wondered if Leslie could expand on that particular aspect.
Yeah, happy to. So I think our recent discussions are still at early days, but I think it's absolutely recognised. So there was that point during the pandemic where we didn't have the PPE supplies that we needed, recognised the impact of COVID in South Yorkshire and Bassetlaw economy, and then what that would mean for health and care, and the role that we play in helping stimulate employment in South Yorkshire and Bassetlaw. So examples of that were local industries being able to reprofile what they were doing to support the endeavour, securing our supplies. We're a big spender in the NHS, so being able to secure supplies locally, and indeed the final year students coming into employment in South Yorkshire and Bassetlaw, a really big aspect of that. So I think there's lots more to go at, and I think I would just agree that it is really important that we do connect with Sheffield City region on how we support our region to come through the economic challenges that COVID will clearly bring, and recognising the knock-on impact on health and well-being that those economic challenges will bring to.
Just one supplementary.
I think we find ourselves bound together now.
Just one supplementary question on Leslie's response. Very good response, actually. The paper I mentioned by the NHS Confederation, Leslie, the role of health and care in the local economy, are you using that as a roadmap for actually driving your own South Yorkshire strategy forward?
Well, I personally haven't, Councillor Ennis, but I will do as of this afternoon.
Thank you, Chair.
Is there anyone else wants to contribute at all in any way to this particular item? No, it wouldn't appear so. So we are now on to item 8, children's surgery and anaesthetic services. Can I just ask that whoever's going to present this assumes that the papers have been read and brings out the salient points, please. Okay? Because I don't know, it's 12:20. I don't know how people are for time pressure or whatever. So if we can be pithy, that would be helpful, I think. Okay.
Thank you, Councillor Rooney. I'll take it first and then I'll hand over to Anna, and then there's also Alexander and James on the line if they want to contribute. As for your instructions, in a nutshell, in 2007, we put a proposal to the Joint Committee of CCGs that we should deliver children's surgery and anaesthesia out of hours in a different way. And that was considered at the time that we would actually perform children's surgery and anaesthesia in 3 hubs in Wakefield, Doncaster and Sheffield, and that would only affect a small number of children, as most people can wait till the following day and to be done semi-electively. Since then, there's quite a considerable change in the landscape, which is detailed in the paper, not least the fact that we've now got hosted networks in place, that protocols are now standardised, and that the ICSs have developed into much more of a mature system, in a much more collaborative way across partnerships. So it was the clinical opinion that we should actually look at these on a pathway, on a basis and a speciality basis, rather than taking things as a whole. And that's what we've decided to do. So as an example, one of the time critical elements of children's emergencies is twisted testis. There's a significant loss of a testis if left for more than 6 hours. So we believe that those can be safely delivered at the local site. One good example of the way we've actually reconfigured services is within ENT, because children's ENT is wrapped up with adults ENT, and that was a fragile service. And so at the weekends, we deliver ENT services at Sheffield Teaching Hospital for Adults and Doncaster for both adults and children's. And the way we've made that safe is by pooling all the consultants together to have very robust and sustainable rotas on those 3 sites. The anaesthetic skills for children over the age of 3 are present in the district general hospitals. This leaves the sort of acute abdomen and appendicectomies as one of our most vulnerable areas. It's not mentioned in the paper, so I'll mention it now, that district general hospitals for a lot of surgeons actually include a lot of paediatrics. So as an example, a third of the work of an ENT surgeon in a district general hospital is children's, as is orthopaedic surgery, but it's not the case for general surgeons who would do appendicectomies. The second thing, as junior doctors' hours have shortened from horrendous ones to 48, training is more targeted, and therefore for the last 12 to 15 years, general surgeons who operate on adults in the districts have had no formal paediatric training, whereas 15 years ago they would have done. So we are left with a cohort of surgeons who have had no paediatric experience whatsoever. So that leaves the question of how far down the age range can an adult surgeon safely do general surgery on children's, and the general clinical consensus from the clinicians is that cutoff is around 8 years old. There are very few appendicectomies done across the patch, although you think it's common, it's not. So under 8 in a district general hospital, it may be one surgeon could go 3 to 5 years and not see an appendix in a child who is under 8. Appendicectomies are not time critical in the same way as torsion of the testes, so they can be safely transferred in a semi-elective manner during daylight hours. So the clinicians have developed a clinical pathway, and this also includes an acute abdominal pain scoring system to help decide which patients need transferring. And we believe that using this tool and using this pathway, that around 45 children or less per year will need it to be transferred to have surgery done at the children's hospitals in a safe manner. As you're all aware, the acute response to COVID meant that we put all emergency surgery from all the district generals onto the children's site from April and May, and that is gradually being stepped back as we can now release capacity in the district general hospitals, with the exception of the fact that all the hospitals wanted to keep the appendixes under 8 still at the Sheffield Children's Hospital for now. It's also given us a great insight into the acceptability of this from what Alexandra and Anna have said before in terms of the patient feedback. So before I hand over to Anna, we're asking you to consider this proposal, which has been clinically led, and also because it's only affecting 45 children or less per year across the SYB footprint, as to whether your views on whether this needs further public consultation or not. And I'll finish there and hand over to Anna.
Yeah, I mean, I don't think there's anything hugely to add there, Des. I think you've covered everything really well, unless there are specific questions.
I think there's a couple coming your way. Councillor Taylor, I believe you wanted to raise an issue.
Unmute myself now.
Yes.
Can you hear me? I just wondered about my thing is quite simple. It's about transport, getting children to the like basically from Chesterfield to Sheffield. Quite a major job. I mean, I noticed earlier in an early report we talked about taxis and God knows what you'll do. How will that work? With the, obviously you're dealing with children under 8. You're gonna have young parents. There's one worried about, the people will be very upset about it, very stressed about it.
Yeah, and we understand obviously those concerns. I think largely across South Yorkshire and Bassetlaw, children under the age of 6, depending on policy, or children under the age of 5 already transfer to Sheffield Children's Hospital anyway. So this is just an extension to that. So it can feel really scary. And there are processes in place for ambulance transfers to go from one hospital trust to another with a parent or guardian. And obviously we talked earlier about the health and quality impact assessment, making sure that that covered any groups that felt they weren't able to do that and what support processes are in place for that. So you're right, it can be quite a scary thing, but I think what parents are reassured by from the engagement and patient feedback is actually that their child's been treated in the safest place with the highest quality of surgery. And I think actually that quite often mitigates any concerns that somebody might have. So the transfer can feel really scary. You can arrive at a hospital and think, crikey, I'm going to have to go somewhere else. And that brings some anxiety. But the pathway's really seamless. And this has been operating, like we said, for under 506 years already. So it's just a slight extension to that.
Yeah, if I can make a comment on that as well. So if you think about what actually happens, a child will present to a district general hospital and they won't get transferred straight away because three out of 4 people who present with abdominal pain actually don't need surgery. So there's a period of observation, and we're very unique in South Yorkshire and Bassetlaw that all our children now are jointly looked after by the surgeons and paediatricians to give them the best possible care. The second thing is the child will then get pain relief because they will present with abdominal pain, and therefore by and large the vast majority of these will go in a semi-elective way by ambulance transfer with the patients to the Sheffield Children's Hospital. And using this period of observation and using the abdominal pain scoring system, that will massively reduce the need for patient transfer and avoid unnecessary transfers of patients that don't get operated on.
Thank you for that very much. So, can I ask a silly question? I always ask silly questions. 8 is classed as child. Why does 9 become a grown-up? Or is that how? Sorry, Councillor Ellis, I think you might shout at me about that.
That's a very good question, and it's subject to much debate, because if you go to the Royal College of Paediatrics and Child Health and the Royal College of Surgeons, they'll say that a child is 16 and under, and that's it. But this is about the confidence of how far an adult surgeon can come down and safely operate on a smaller and smaller adult, and it's from the clinical view that it's under 8. Now, clearly there'll be exceptions. There'll be very big people who are 7. There'll be very small people who are 8. But that is the general guidance and cutoff. And where there will be some overlap, that's a consultant-to-consultant discussion between the Sheffield Children's and the District General Hospital.
Thank you very much for that.
Are you content with those answers, Councillor Taylor?
Yes, thank you. Yes.
Okay.
I know a big children and a small child. I'm a small child.
Councillor Ennis, I believe you wanted to raise an issue earlier.
Yeah, thank you, Chair. I mean, we've obviously done the modelling of up to 45 children a year that's be affected by this proposal. I'd just like to ask if that figure is way out of kilter, say it was 100 or 150, whether the ICS would come back and inform us about that and what we would probably do with that. The other thing is, we're not going to see a lot of smaller, and this to me is a small change, so it doesn't need a full public consultation exercise as far as I'm concerned. But let's say, for example, there were another 4 or 5 different changes to other small aspects of surgery over the course of the next 2 or 3 years, then that might constitute a substantial change overall. So I wanted to seek assurances that these small changes will only come in. Hang on. My computer went off then, Chair.
No,
These small changes will be fairly. I'm trying to get the words out. There won't be many of these changes in the future coming through on an ad hoc basis.
If I can take the first bit of the question, during the pandemic, all appendectomies were transferred, and so I think the figure was about 1 a week for everybody under 16, and therefore that'll be very much less for the people who are under 8, and the under 5s actually come anyway. So I think we're reassured on that. I think the team under Alexandra and Anna and James did a very good job at data collection and have very robust data about what actually happened during that time, and that reassures us that we think the numbers are going to be very low. And as we have done with the children's surgery and anaesthesia, if the landscape changes, then it's only proper and right that we do revisit these things and bring it back to this committee.
Thanks for that, Chair.
Are you content with those answers, Councillor?
I am, thank you, Chair.
Okay. Is there any other questions on this item? Councillor Robinson.
Thank you, Chair. Yes, just following on from the point Councillor Ennis made, I think my sort of concern or thought that goes through my head is that over time, if we gradually increase the amount or the occasions when we're transferring children to Sheffield, is there a danger that parents start to lose confidence in the treatment of children in district general hospitals? You know, are we in danger that they're going to feel that that's inferior care and you know, be concerned by that?
I think that's a very good question, and in fact, actually, these proposals have actually decreased the number of patients going through to the Sheffield Children's Hospital rather than increase them. All we are proposing is a slight increase in the abdominal ones for very good reasons. And I think, I think our district general hospitals provide excellent services, and they'll continue to do so. But you've got to consider that, is it right for a surgeon that only operates on an under 8 abdomen once every 3 to 5 years? Intrinsically, that doesn't seem right to me. And I think during the patient feedback from the pandemic, we got very positive feedback. So this paper and the proposals are actually making more emergency work happen in the district generals and not less.
Okay, happy with that. James Scott.
Yeah, just to add to that from Des, I think the work we did around this, when we looked at the various pathways around torsions, around ENT and around appendectomies, gave us great assurance of the quality and the standard of the work that's happening in our district general hospital. So as Des says, there were some issues around the appendectomy pathway specifically, which we felt needed addressing. But actually, we felt that there was a really strong basis for maintaining work in our district generals, and you know, we're really happy to communicate that.
Okay, thank you very much. I think it's Councillor Robinson makes a fair point in that if you continue to take away, not in this instance, but continue to take away services from a particular hospital, then that sows the seed of doubt in the general public as to whether or not they should be going to that hospital at all. So I'm sure that clinicians and decision makers are cognizant of that potential unintended consequence, you might call it. Any other questions? No, so I think we're being asked to express whether or not we think this should be the subject of further public consultation, and the answer to that is no, we don't. We think that it's you've gone, well, bent over backwards would be an expression to talk to people over the last, is it 4 years or so? And we've an agreement that we don't think you should be doing any further.
Thank you.
Okay. All right. Right. Update on hyperacute stroke services. Again, pithy, if you could. Whoever it is, somebody talk to me.
Hi, Councillor Rooney, it's Jamie
Hello.
again. I will try and be as succinct as I can.
Thank you.
So thank you for letting me join you today. So I came into post in January 2020 as Network Manager. And I'm actually a clinician by background, so I'm a stroke specialist physiotherapist and a pathway manager, so I understand stroke services well. So I wanted to give you an update on HAZU, on the new model of care, talk to you a little bit about the progress of the stroke hosted network, and also just describe what we've been doing during the COVID incident as well. So the HAZU changes were approved in 2017 after a comprehensive review. Implementation was progressed through 2018, and the new model was enacted in July 2019 for Rotherham patients and October 19 for Barnsley. So hyperacute stroke unit care is typically offered for up to 72 hours post-stroke. And the focus of that is to offer brain-saving and life-saving treatment. And that requires a specialist multidisciplinary approach. And what we're offering now in Sheffield, Doncaster and Wakefield is just that. So we're offering specialist care. And each HAZU is being set up and designed to meet the national guidance and the service requirements that were laid out for them. As I described earlier, the patient flows have generally been as expected, with patients presenting to Doncaster being slightly lower than expected and greater in Sheffield and Wakefield. And since July 2019, 590 Rotherham and Barnsley patients have passed through the pathway. We've had positive feedback from patients on the ground, and the latest FST results, the friends and family test results, as I've described here, have been very positive. And what we've seen as a network team that provides to work well together across the pathway. I've described that we're going to do an evaluation report, which will include patient and family feedback on that. We've been monitoring the audit results, so that with SNAP, as we call it, which is a national audit where every patient is entered onto that, and it measures quality and it gives us a good indicator of whether services are offering patients and families what they need. And we can see from the last quarter actually that things are improving. It's an improving picture, with our services actually performing very well against others within in Yorkshire and the Humber and nationally. So Doncaster achieving an A, Sheffield achieving an A, Wakefield achieving a B. The post-performance dashboard that will be in use as we move into the recovery phase of COVID pulls together some of that information. We were concerned that we wanted to avoid any delays. So these delays are related to patients waiting to go from a hyperacute stroke unit back to their local hospital, and we've been monitoring that. And there have been 37 reported delays out of 590 patients, so around 6%. And what we can see is the median delay for that is 2 days. And the reason for the delays is sometimes related to bed availability. So the Rotherham unit in particular is a mixed unit of stroke patients and medical patients, and so they have to utilise their beds for both types of patients. But where those delays have occurred, the teams work together to try and resolve them, and there's a daily call in place to do that. And what I wanted to give you assurance of is if patients are waiting to go back to Rotherham or Barnsley Hospital, they continue to receive the specialist care. The therapy teams, the nursing and the doctors all continue to work with those patients and offer them what they need. We had a review meeting last week which involved all organisations across the pathway, including the ambulance services. And we agreed some key actions there. So we're going to do some work to refine the daily call that we have between services. YAS in particular, looking at some of the patient flows. We're going to look at the delay reporting mechanism and make sure that that's as robust as it can be. And Rotherham are going to do some internal work on how they can improve their ability to create beds on their stroke unit when they are at capacity. In terms of the stat results, overall, really good. A couple of areas that we want to do some focus work on, and that includes thrombolysis, so the percentage of patients that are thrombolised and receive the clot busting drug. And Mid Yorkshire have got some work to do on their speech and language therapy pathway, so they're in the middle of recruitment at the moment, and they're aiming to offer a 7-day service of speech and language therapy. In terms of the network, so we began in January 2020. We've got a team as part of the network, there's myself, and we've got 2 clinical leads, an allied health professional and a stroke consultant. We've also got support from a data analyst and a workforce lead and admin support. The focus of the network is on clinical standardisation, innovation and workforce improvement. And what we want to do is make sure that the network works to deliver on the long-term plan, and also that we consider all the regional priorities that the ICS and the organisations have. We've got a focus on engagement and collaboration, so we're there to support those collaborative conversations, and we've got an infrastructure in place to support that. We have steering groups and subgroups, and we want to work with patients and their families. And the Stroke Association sit on our steering group, and they've been able to support us with some patient engagement work. And during COVID, we were able to accept an offer for the Stroke Connect service, which is about offering patients a phone call post-discharge from the Stroke Association to give them support. And in Doncaster and Bassetlaw in particular, there aren't any Stroke Association services in place at the moment, but this Stroke Connect service is actually allowing patients to seek better support, and so we're really pleased to be able to put that in place. Networks are developing across the country, and there is a commitment from the government and nationally to develop integrated stroke delivery networks, and our hosted network will look to move into that role. We've been able to make really good links across the national arena, and that's been acknowledged really by the National Clinical Director for Stroke, who feels that we're in a really strong position within our area. Our work programme's been shaped, and it will pull in all those things that I've mentioned already, the national guidance, the areas of improvement that we need to make across the region, and we'll consider how we will the services from a COVID perspective. And we'll use data and patient experience information to help inform that. Patient engagement is at the centre of what we want to do with the network. We've got an engagement plan, and we're looking to do some key pieces of work around, firstly, understanding how patients have experienced the COVID incident when they've had a stroke. Have they been able to access services? Have they received the care that they would want to receive? We're going to do some work on hazard, and we're also interested in rehabilitation, because it's focused on hazard. The first 72 hours, rehabilitation is much longer than that, and we want to try and improve efficacy across the system. And then from a COVID point of view, we've taken a lead role as a network in supporting providers to work together to find solutions to problems that we encountered. There was a national concern that we might need to rapidly implement changes in stroke pathways, as has happened in other places in the country. But actually, within South Yorkshire and Bassetlaw, the pathways that we have got in place were sustained throughout the COVID period. Stroke services continue to offer high quality care, access was maintained across the whole stroke pathway. So we worked together with everybody across all of the services to understand what the impact of COVID could mean to stroke services and to see if we needed to make any changes. We worked on some of the priorities flagged to us by the command and control system. That was make sure you can continue to offer thrombolysis and ensure that your rehabilitation pathways have capacity to take patients, and that's what we focused on. We monitored demand and capacity throughout the COVID incident, and we will continue to do that. We developed some community guidance to help services in adjusting and adapting their approach during COVID. And we also saw some adapted ways of working for TIA and review services. The patients continue to be able to access those services, to access stroke reviews, but we saw the adaptation of remote technology where patients and families could use that. We saw different ways of working, which were all really positive. And we've been trying to capture the learning from that so we can understand what do we need to carry on with, what do we want to amplify, what do we want to improve further. So we've run a series of workshops with clinicians, and we're talking to patients. So in Sheffield and in Barnsley in particular, they've been asking patients questions in their review clinics about how they've experienced the stroke services during COVID. And we're aiming to replicate that in each of the places. And we've got some telephone surveys happening today carried out by our clinical lead to really understand how patients have been getting on. The next steps for the network, we're identifying the key areas of work. We're aiming to understand all the services that we're capturing the current state, seeing where there are any gaps. We want to include elements of the recovery planning for COVID. So there's a national document that we're trying to translate into services. We're focusing on things like thrombectomy, thrombolysis, rehabilitation, engagement with patients, innovative ways of working, workforce development. We will be using the dashboard when that's back up and running, and we're producing the report that we can share with you. And we're just preparing if the second wave does come, is there anything different we need to do from what we've learned from the last few months, and just make sure that we're prepared. We will be sustaining services for stroke, and there's no reason why they shouldn't be sustained. So finally, I just wanted to make you aware that the hazard implementation is being successful at the minute, and we will be continuing to monitor it, and we've had a really positive initiative of the network.
Thank you. Do any of your colleagues want to add anything to what you just said? If not, I will take question.
Absolutely, just a reminder that there's an outstanding public question on stroke.
Yes, I'm trying to find it, Emily. I'm trying to find it.
Nora's been brought.
Go on,
Nora's been brought back in to ask it, so she's on the screen.
Ah, good. Hi again, Nora.
Hello. I'll make it brief. The first two questions. The first one was about the thrombectomy, which is a new service and very time limited. I wondered how long it had been offered in Sheffield and how many actual thrombectomies had been done, and how did you ensure that the person carrying out the procedure had the relevant skills and experience, as you do with all the other procedures you've been talking about? And the time limited bit, will Barnsley people be assessed for thrombectomy before transferring to Wakefield? That's the first question. The second question, very brief, the numbers in your report were 22 cases per month per town from Rotherham and Barnsley in the last period, went up during the pandemic to 32 cases per month being transferred. Is there a reason for that?
Thank you, Councillor Rooney, and thanks, Nora. It's Des here. If I can take the first question and then I'll pass Jamie over for the second. So, mechanical thrombectomy is a relatively new procedure. We've offered it in Sheffield since April 2018, and since then about 57 patients have been done. It's not a service that you can switch on instantly because at the moment there are only 3 neuroradiology specialists that are actually trained to do it. As there are similar numbers in Leeds, and so it's not something that you can switch on to all patients overnight. As far as the expertise is concerned, it does take about 2 years to actually train a specialist to actually do this procedure, but it's not dissimilar to other types of procedures that these specialists undertake. So, for instance, it involves putting a very small wire through an artery in the groin and actually steering that up into the brain. And they would do that to put coils in, they would do that to put sort of dye in to studies. And so they're doing the same thing just to remove a blood clot. So it's not dissimilar from some of the other procedures they undertake.
Excuse me, Des, could I just interrupt you for a moment? Councillor Keenan is struggling with her IT equipment and wants to, at the very least, get a question registered, even if she doesn't have time to hear the answer before her battery goes flat. So, Councillor Keenan, could you at least get your question registered, please?
Thank you very much, Chair, and I'm so sorry to interrupt, Nora. I really just need to get these questions out. The first thing is I understand as well that there is a link between certain strains of COVID-19 and increasing strokes. Will you have you anticipated and seen an increase? I'm reassured about the transfer, but that was really important. And I also heard that you said in your report that you've undertaken detailed research into patients in Doncaster and Barnsley, and you intend to do that again in the other areas. When are you intending to ask Rotherham service users about their experiences, and also a question about the rehab services during this pandemic? So it's a bit muffled, so I'm trying to get it out as quick as possible.
Okay,
Thank you, Chair.
Have you finished? You done it? Des.
So Jamie, do you want to take that one, and then I'll continue with thrombectomy, because obviously it's not related, but just as a matter of interest before Jamie answers that question, the thing about COVID-19, it causes clots in virtually everything. So it's not just brain, it's heart and it's lungs, and it's in other organs of the body. It tends to make your blood very, very sticky. So
Could I just ask, Des, that you actually finish Nora's answer, if you wouldn't mind, because it just makes life that bit simpler for the minute taker, for example. And I'm sure as long as Councillor Keenan has got a question said, she will be happy with some recording of the answer. We will send her your answer, and if she wants to take it further, she can do that by email. Is that okay?
That's fine. I'll continue. So I think I've answered most of Nora's questions, apart from the specific question about Barnsley. So how the service will operate is that anybody who presents with acute stroke goes to the hyperacute stroke unit first. They don't get pre-selected for thrombectomies in the district general hospitals that don't have hyperacute strokes. So anybody in Barnsley would either present to Doncaster, Sheffield in a rare instance, or Wakefield to have their CT scan and their thrombolysis, and then be considered for thrombectomy at that point. And then they'll either access those services in Leeds or in Sheffield, but predominantly Leeds.
Okay.
I think I've answered all those questions, Jamie and Alexandra.
Nora, are you? Has he answered them all?
The increase in numbers from 22 cases per month to 32 cases after the pandemic lockdown. Why?
I to that one, Nora, for you, if that's all right. I'll go with that one first, and then I'll answer Councillor Keenan, if that's all right.
Okay.
So
all right, yeah.
Numbers, yeah, and we've been managing demand. What we've seen across South Yorkshire and Bassetlaw as a whole is that there has been a slight reduction in stroke admissions across the region. So that's including all patients. But for patients from Barnsley and Rotherham, admissions have remained fairly stable. And it's not unusual over a year to see some fluctuations in stroke admissions. So historically, as a clinician, I would often have seen a slight reduction in the summer months, for example, and a slight increase in the winter. So it's not unusual to see fluctuations. And we did see a rise in Rotherham admissions in March and a rise in admissions for Barnsley patients in June. What we did see is that across the region, we did see a reduction in presentation to hospital across South Yorkshire and Bassetlaw. And there was a national concern that the stroke patients wouldn't present with stroke symptoms. And so there was a public campaign led by the National Clinical Director. There was a lot of social media use, Twitter use. People went onto the news to try and encourage people to present. And within South Yorkshire and Bassetlaw, each organisation did their own kind of communications planning for that. So, for example, one of the stroke nurse consultants within the region from Sheffield went on to look north and encourage patients to present. We also saw examples of case studies being released on websites where patients were describing the fact that they'd approached, they'd been presenting to hospital with stroke and why that was important. So I think what that did for us in South Yorkshire and Bassetlaw is it helped us ensure that patients still did present. What we did see a reduction in these patients presenting with what looked like a stroke, but then on investigation was identified as not a stroke. So we saw a reduction in stroke limits. And because all of the services continue to function right across the pathway from TIA services to pre-hospital, through acute and into rehab, I think that enabled us to manage patients appropriately. And we were able to continue to offer thrombolysis and thrombectomy services throughout COVID. Because the dashboard has been in development and was paused during COVID, I've had to rely on information provided by the service managers in terms of the data. And that data comes from the SNAP audit that I mentioned earlier. And what you find with SNAP is that the data is continually being updated. And so in the second report for June, what might have happened as well is that we did capture a few more patients in the overall number when you compare to March. So although it looks like more patients presented between March and June, actually as a whole, I think it was fairly steady. And once we've got the performance dashboard up and running, I'll be able to monitor the numbers much more carefully and closely. So I think it's a combination of the fact, really good messaging to the public, please come to hospital if you have symptoms of a stroke. All the clinicians were very active with that as well, as we were with the network, and a combination of the data being refreshed. Is that all right, Nora?
Thank you.
Yep, okay.
Okay,
I've lost
so,
Councillor. I've lost Councillor Keenan.
Oh, I can still see her on my screen. So do you want me to just pick up on those questions in brief? So in terms of stroke and the incidence of stroke linked to COVID, the clinicians are doing some work on this. And so our clinical lead, Jess Redgrave, has been talking to our clinicians to ask them to look at the latest evidence for COVID in relation to stroke. What we've seen is we've had very few patients that have been admitted with stroke and COVID. So we in South Yorkshire and Bassetlaw, what I'm hearing from the consultants is that actually we aren't seeing an increased incidence of stroke in relation to COVID within our area. But that being said, evidence is coming through all the time about this matter. So I think as a network, what we will want to do is keep an eye on the latest evidence and ensure that our services are able to respond to that appropriately. And I know our clinical lead is very interested in that and is tracking any new evidence that comes out. From a Rotherham point of view and from a service point of view and seeking their views, one of our clinical leads is actually one of the team leaders at Rotherham. And so the work that she's doing today to capture patient experience, she's got a cohort of Rotherham patients where she'll be able to pull in some information of their experiences. So I think the mechanism might be different in how we gather that information in from Rotherham patients, but nonetheless it will still be done. And in terms of rehabilitation services, some of the questions that we're asking in the telephone reviews today focus on rehabilitation. So did somebody come and see you face-to-face at home and offer you stroke rehabilitation? Did you receive face-to-face hands-on rehab, or did you receive remote rehab? So using technology just like we're using today. And what was their experience of that, and how did they respond to that? And we've got a speech and language therapist in Doncaster as well, who's pulling in some views about the use of remote technology for communication therapy too. So we've got different activity happening in different places across the place.
Councillor Keenan.
Yes, thank you very much for that. I just would maybe ask if, when you do have that data drilled down for Rotherham, that we get it, and or if you report that back to Rotherham Health Select. Thank you.
Just ignore it.
Thank you, we will.
If that's okay. Thank you, Chair.
You're welcome. Has anybody else got any questions? I've got one which might feel a little bit perverse, but for this item and any other item, if things go horribly wrong, where do you have that discussion? Do you know what I mean? Because you're not likely to come here, or it's very unlikely that you will come here and say, sorry, Guff, got it wrong, and it all went horrible. If there's an issue like that, where's the dissection take place? Is that a reasonable question?
I can talk to you a little bit, Councillor Rooney, about the governance structure that we've got and how things would be escalated to, and then I'm not sure whether Alexandra, Ellen and Des might want to add something around that. In terms of the Stroke Hosting Network, we've got a number of subgroups, and they involve clinicians and key leaders across the patch. And so if something within stroke services isn't working well, or is something that we need to improve on, the subgroup will discuss that, and then it will get fed into our steering group. And at our steering group, we can raise issues for consideration. And in turn, we then are accountable to the chief executives for the acute organisation. So there's a clear governance structure for the network that's being set up. And also, I think if it's something very small on the ground, we have the daily calls. We've got really good links with everybody across the patch, so we can quickly understand if something's not working well. And during COVID, we were able to send reports into command and control system and ask the chief executives for their support or just to focus. I don't know whether Alexandra or Helen would want to add.
Well, Alexandra's got a hand up.
Yeah, it's nice being able to put a real hand up rather than a virtual hand up. So I think it's worth just adding to Jamie's answer. Ultimately, the individual providers are the statutory organisations with statutory duties around patient safety and quality. And so every trust has its own standard processes. If there is a big risk, if there's been a serious incident, then trusts have very well established processes for saying, this is a problem, examining it, identifying anything that's gone wrong. So in the first instance, if there's been, for example, a particular issue with a particular patient, that would get picked up through the absolutely, the standard and the required processes within that trust. The network and then the shared working then comes in over and above that, as Jamie's describing. So if there's an issue which has been about, specifically related to the transfer of patients between sites, for example. And similarly, the ambulance services, again, have their own standard review processes. Okay. So I think it's a two-layered thing. There's a statutory thing in the individual organisations, and then there's the work that Jamie's describing, which would be about reviewing how the system has worked.
Okay, thank you. Thank you very much. Anything else on that item? Otherwise, we'll move on. Councillor Robinson.
Thank you, Chair. Thank you, Chair. I just wanted to query, you did a couple of things. So firstly, not that I represent Wakefield, but I did note that Wakefield got a B, whereas the others were an A. And I just wondered if you could just expand a little bit further on that. And also whether this rating just refers to care that's received in the first 72 hours after admission, or whether we're also talking about about the rehabilitation afterwards, which you did touch upon in something of what you said. And in your report, it talks about local follow-up for community rehabilitation. And what I wanted to know is whether that's delivered by therapists who are stroke specialists, or whether that goes out to generic teams, and whether, what your view would be on that. I mean, in lots of ways, there's lots of positive feedback here from people, but when care is delivered kindly, people tend to highly regard it, and they're not always able to differentiate about the level of expertise that's being applied to the meeting of their needs. And that just sort of put that into the equation as well. Thank you.
Okay, thank you, Councillor Robinson. So Wakefield and their results. So they have a clinical lead who's responsible for SNAP, and that's Mike Carpenter. And we've had a conversation with Mike about, the rating. So when you look at the Wakefield results, on the whole, actually the service, it looks very strong. The main area that has just taken them down from an A to a B is the speech and language therapy. So that's the speed of assessment and whether the level of intensity of speech and language therapy actually meets the national guidance. So I think this is an area that on this occasion they've been a little bit lower, but on previous occasions it's been a lot higher. They've had a number of speech and language therapists that's moved on, and so they're in the middle of a recruitment effort to bring their speech and language therapy service back up to where it needs to be and offer a really good 7-day service. And when you actually look, not only do they score a service, they also give them a numeric number score. And so the Mid Yorkshire is about 4 points off of Doncaster and Sheffield, which is a really kind of small marginal amount. So I think Mid Yorkshire have a plan in place as to how to improve the elements of their SNAP report that needed improving. And there's a clinical quality meeting this afternoon chaired by our clinical lead, Jess Redgrave, who is going to be focusing on the areas of improvement for each of the services. And we've also had some getting it right first time reports that have come through within the last week. And within each of those is an action plan for each organisation to look at and work through in order to improve services further. And I'm confident that Mid Yorkshire will be doing that and working through that. In terms of the SNAP results that I've shared you today, they are related to the first 72 hours of care. So for SNAP, each team has its own unique coding, and pathways are split into teams. So there is the hyperacute stroke unit teams in each area, which are the hazard results that I've shared with you just now. And then the rehabilitation teams and the acute stroke unit teams will also have their own individual reports. And then that all gets put together in what we call the patient-related, patient-centred data. So that will include, for Rotherham, any patients that have been through the different systems in Doncaster. So yes, there are results across the pathway that we can look at, and as a network, again, we're looking across the pathway. We're not just focused on hyperacute stroke unit care. And then in terms of community rehabilitation, across South Yorkshire and Bassetlaw, we're in a very fortunate position because all of the community teams that we have are stroke-specific specialist community teams. We have early supported discharge teams now in each place, which are all stroke specialists. And in order to be a stroke specialist, you have to be treating patients 80% of the time. And again, we've been meeting the teams, and I'm confident that the teams are specialists that are delivering the care to these patients. That's particularly important for the first part of rehab as well. There are generic services that patients do access, but it tends to be later down their pathway and when it's appropriate. I'm hoping I've answered all three of those questions.
Okay, Councillor Robinson. Okay, I think that's probably the end of that item. Unless anyone else has got anything to say. I don't think so. So I think we're just noting that, I think. And Emily, your moment has arrived.
Thank you. Nothing to add really to the report on the changes to the terms of reference of the committee. It's just putting in the change that Wakefield have left. We've slightly changed the operating arrangements of the committee, and obviously I guess we'll kind of keep it under review as things change, but there's nothing to add beyond that.
Okay, so basically we asked to accept them, not that we can't anyway, can we? No. Okay, so we're accepting those changes, and I think the next bit is the next meeting, is it? Is that right? Because I can't see in the agenda. My assistant has left me. The next item is the next meeting, isn't it? Councillor Taylor, sorry, you wanted to say something?
Actually, we'll do the next meeting first, but I'm going to congratulate yourself then.
Oh, all right.
On the hard work.
We haven't really established a sort of routine in terms of meeting, have we, for a variety of reasons. Well, first of all, there wasn't one. So how does, where are we now? July, August, September. How does October sound?
Yeah. If I could just respond to that, Councillor Rooney, I think that would work really well as a suggestion. It's quite possible that the gluten-free work, which has restarted now, will be able to come back for that time frame.
It wasn't just a guess, that, you know. I knew that. Okay, October it is then, and I think that's about it for today, isn't it? Councillor Taylor.
Right, I'm going to congratulate yourself on conducting this meeting today. It's been flipping hard work. I can imagine I can see the lady next to you helping you. I've never ever done a meeting before. Halfway through the meeting, my dog has jumped out from the table, gone mad and tried to bite the postman. And that's got to be a first on a meeting. So
that's not to do with me, is it?
No, nothing to do with you. It's the postman coming sneaking up on her.
Okay.
But anyway, well done, well done. It's been a very difficult meeting, and thank you for doing it so well.
Well, I don't think it has been a difficult meeting. I think it's been a very orderly conduct, well-mannered, professional, properly done meeting. I don't think it's been a hard meeting at all. I mean, it's a bit confusing on the screen when people move around and then trying to look at three different pieces of IT equipment. But no, generally speaking, no. And that's down to yourselves. Okay. Right. I think we can... oh, yes. One final thing. Safe journey home. Bye.
Thank you.
Bye. Thank you.
Thank you. Bye-bye.
Cheers.
Thank you. Bye.
Bye.